안녕하세요. 단국대학교 치과대학 이준석입니다.
Greetings, I'm Professor Lee Jun-seok of Dankuk University Dental School. Today I'm going to talk about the prosthesis type for posterior implants. This is the contents of today. I'm going to talk about characteristics of various types of prosthesis, and I'm also going to talk about factors to consider when selecting prosthodontic types. After that, I'm going to summarize and end my lecture. First, let's look at the characteristics of prosthesis. Characteristics of posterior implant restorations. Foremost, the posterior area serves a primary role in mastication. Masticatory force can vary depending on dentition and oral condition. Also, it can be divided into maximum biting force and habitual biting force. On natural teeth, vertical force is applied vertically, but on restorations, vertical and horizontal force is applied at the same time. Let me quote the research by Lundgren and Laurel. They report that the maximum unilateral masticatory force is 320 newtons. On the other hand, the habitual masticatory force is 100 newton, about 32% of that of maximum masticatory force. Another trait of posterior area is that it does not have a lot of space for restoration. The ultimate goal of posterior restoration is to maintain the function of posterior area and to minimize complications. The most common complications in posterior restorations, what are they? It may vary depending on study, but the most common complications are the following. First is failure in retention. This includes a screw loosening, failure of crown. Second is fracture of components. This includes not just screw implant, but also ceramic fracture as well. As you all know, implant restorations include the following: screw retained, cement retained, dual retained restorations. Let's look at the characteristics of various restorations. I'm sure you may know more pros and cons than what is displayed, but compared with the concept of older days, the pros and cons have changed, and I've summarized it. First, the screw-retained prosthesis. It is very easy to retrieve it. Also, it is consistently retained by 30 Newton centimeters. It does not have any excess cement. It is a major plus in terms of retention. It is screwed tight, therefore it can be used for small vertical spaces. The downside is if the access hole is positioned labiolingually, this can be a problem epidemiologically and aesthetically. Therefore, placement angle and position plays a significant role. Currently, compared with the cement type, it's more costly to fabricate, and to get passive fit, a lot of effort and process are involved. Also, ceramic chipping is known to occur more frequently compared to cementation type. The pro of cement-retained prosthesis is that you can get passive fit very easily. The cost of fabrication is cheap, and it uses the traditional prosthesis fabrication method. It is very familiar to us, and at the same time, it's quite aesthetic. Also, it is not affected by the implanted position. Good aesthetic and epidemiological prosthesis can be provided. However, it is very difficult to remove excess cement. Because retention is not consistent, it can be weak or excessive. For cement retention, it requires more minimum vertical space. So what is the most ideal type of prosthesis in posterior zone? In conclusion, no such thing exists. They can be applied to all cases, and depending on different situations, we need to understand what kind of risks there exist. We need to understand if the masticatory force is strong, how much space can be secured, implant placement position, the probability of future complications, and which of the complications are more likely to occur. We need to understand that. Let me talk about minimum vertical space. From the gingival margin and up to the antagonist, if it is at least over 5.5 millimeter, all types of prosthesis restorations can be provided. However, if it is below that, only screw-retained prosthesis can be provided. Cement type or ER type requires space for cement, therefore, it requires at least 4 millimeter of abutment height. However, in the case of screw-retained prosthesis, for retention, as shown in the image, if the space is beyond that of the screw head height, theoretically it is possible. As a result, if there is at least 4.5 millimeter, prosthesis provision is possible. Please remember this. I'm sure you'll get the gist if you look at this clinical image. The height is so tight that it is not enough to do final sealing. In this prosthesis type, if I had provided cement-retained prosthesis, this is not going to last long. In this case, in number 47, single implant was placed. I'm sure you have this kind of experience as well. What we need to focus on in this case is the direction of how load is applied and the amount of vertical space. Because axial loading is not visible and because the patient has tight vertical space, you need to think about potentially frequent restoration failure and screw loosening. In this case, you need to provide screw-retained prosthesis so that it is retained with irregular force. This is the same for this case as well. In the upper, the maxilla is resorbed anterosuperiorly. In order to secure 1.5 millimeter of buccal bone, we place the implant more palatally, and at times we tend to over-contour the buccal side. In order to provide cementation type, as shown on the right, the abutment needs to be modified. Comparatively, the force applied on the buccal side leads to lateral force, and the abutment form, like this, cannot resist such lateral force. As a result, you need to choose a screw-retained or ER type prosthesis in this case. When you provide implanted treatment, we inevitably come across contact loosening and fracture. As shown on the left, there is contact loosening. There are many ways to solve this, but if you can retrieve it, regardless of the way you take, it can be resolved very easily. But due to aesthetic reasons, if you provide cement-retained prosthesis in the lower and if there is contact loosening, at times it may be difficult to retrieve the prosthesis. In this case, you can build up resin on the adjacent natural tooth. This is not an easy job, both in terms of effort and cost. Retrievability is very important. Next is a case using solid abutment. It's a very good method, but this kind of problems can occur. Screw loosening occurred within 3 years after delivering solid abutment. This is a prosthesis form which is tightened by 35 Newton centimeter, and screw loosening occurs very rarely, but once it does, we cannot tighten the abutment in the same position. Therefore, whenever there's abutment loosening, we need to provide a new prosthesis. All prostheses have fracture potential. However, if this can be retrieved, this is not an issue. On the other hand, let's look at this situation. When you utilize CAD/CAM abutment technology, even if the interarch distance is significant, we can provide restorations. However, even if you use the longest abutment, there can be significant occlusal clearance. In this case, it is better to provide cement-retained prosthesis to minimize ceramic fracture and lab error. Now let's talk about retention control. At times, the retention can be weak or it can be excessive. In the case of cement-retained prosthesis, it is influenced by abutment length, abutment convergence angle, abutment diameter, and the load that is applied. It can vary significantly. As shown in this image, when the abutment is short and retention is low, it can lead to failure, and if you use sandblasting, contact surface can be widened. However, in extreme cases, if you cannot remove crown although screw loosening occurred, we can form screw hole on the occlusal surface and solve this problem. As shown in this image, if the screw is loose, but if you cannot find a screw access hole no matter how many holes you make, in this case, you need to remove the prosthesis and adjust the abutment to reduce retention and form a new restoration. In terms of retention control, screw-retained prosthesis is much more favorable. The fatal downside of screw-retained prosthesis is aesthetics. If you make access hole like this in the lower and fill it up with resin, unaesthetic access hole can be exposed. As a result, some people prefer cement-retained prosthesis. However, we can solve this issue by using Teflon tape and opaque resin to mask the metal that can be shown through. If you use resin to seal afterwards, then you can make sufficiently aesthetic prosthesis. ER type is a combination of advantages that you can enjoy with a screw-retained prosthesis and cement-retained prosthesis. It is retrievable and you can get easy passive fit. Also, excessive cement can be removed easily. You can use angled driver to get more epidemiological and aesthetic ER prosthesis. This is a summary. The primary purpose of prosthesis is to maintain function and to minimize complications. We need to determine what is the most important factor clinically, and we need to find the right type of prosthesis to satisfy such requirement. Controlling retention is a very important factor that we need to bear in mind. Today we talked about determining the restoration type for posterior implants. Except for when impossible, all restoration types can be used. But depending on the case, there are many important factors to consider, so it is most important to choose restoration type that can easily solve the issue at hand. By making such choices, you'll be able to minimize future problems. Stay tuned for the next lecture. Thank you for watching.